This program is brought to you by Emory University.
It is my pleasure to introduce my friend and colleague and one of our own, Dr. Ijeoma Isiadinso, who is presenting today on non-alcoholic fatty liver disease. Dr. Isiadinso is an associate professor and now the director of our Heart Disease Center for Prevention. She hails from the Northeast, went to Temple University for internal medicine and cardiology fellowship, and was a chief fellow there. She moved to Emory about 10 years ago. And she's not only certified in echo and nuclear medicine, and provides just outstanding patient care. Patients love her, but she also has a passion for education. She serves as a course co-director for our annual Emory Symposium on Coronary Atherosclerosis and Prevention, the ESCAPE meeting, and also the annual Women in Heart Disease conference that we have every year. She's received an award for excellence in service at Emory and is a top doc. And we're very excited to learn from you today about non-alcoholic fatty liver disease.
Thank you very much, Dr. Mehta, for that introduction. So I, this morning, will be talking about cardiovascular disease in non-alcoholic fatty liver disease, focusing on identifying and managing cardiovascular risk. This financial disclosure is not relevant to this particular talk. This is the outline. I'm going to touch on epidemiology, then move towards pathophysiology of non-alcoholic fatty liver disease and associated cardiovascular disease. For just ease of the discussion, I'm going to call this NAFLD because I'm going to say non-alcoholic fatty liver disease about 600 times during this talk. And then lastly, I'll talk about treatment. So what is NAFLD? NAFLD is the most common liver disease in the United States and in fact worldwide. The prevalence in the United States is about 25%, but the prevalence is much higher in specific high-risk populations. So in the diabetic population, the prevalence is anywhere from 50 to 75%. But when we look at patients who are obese with BMIs above 30, the prevalence increases to 80%, and it's actually above 90% in individuals who have a BMI above 40. The global prevalence is depicted here where on average, the global prevalence is 25%, but it definitely varies depending on the region that you are looking at. And so the highest prevalence of NAFLD is 30% in the Middle East and in South America, and lowest in Africa, where the prevalence is 13%. I'm pleased to say that in Nigeria, the prevalence of NAFLD is as low as 9%, which is one of the lowest I saw during my research. And then, as I mentioned, North America, Europe, and Asia are about the same in the 20s. This is data from UNOS looking at the etiology for liver disease resulting in liver transplant. And as you can see here, the #1 cause for liver transplant remains alcohol-related liver disease, but a close second is NASH. And it's projected that by 2030, non-alcoholic fatty liver disease will overtake alcohol-related cirrhosis as a cause for liver transplantation. NAFLD is primarily asymptomatic and it's really an incidental finding. The first clue is usually elevated transaminases that prompt further evaluation. It is the most common cause of abnormal liver test results among adults in the United States. Non-alcoholic fatty liver disease is actually a spectrum of disorders that begins with something as simple as just fatty liver infiltration, also known as steatosis, and then the extreme complication and results of hepatocellular carcinoma. The good thing is that 70% of individuals who have NAFLD are actually just going to have steatosis, and they're going to remain pretty much very stable. Only 30% of that group is going to progress to develop non-alcoholic steatohepatitis, so where you have steatosis and inflammation as well. This is important because we really have an opportunity to employ lifestyle modification to prevent the progression from steatosis to NASH. And we'll be talking a little bit about that later on during the discussion. About a quarter of patients who have NASH will go on to develop cirrhosis. Most patients who are diagnosed in the middle age, about 40s or 50s, when you start to see a higher prevalence of some of the risk factors for NAFLD. However, we are seeing an increased prevalence of NAFLD in younger individuals, and that seems to mirror the rise in increasing rates of diabetes and obesity in the population as well. So this is a slide just summarizing the prevalence of NAFLD with age, or by age rather. And as you can see, the prevalence of NAFLD increases with increasing age. And not depicted here is that the prevalence of NAFLD-related complications like NASH and cirrhosis actually increases with age as well. There are gender differences also noted with the prevalence of this disease. This was a summary of several population-based studies that looked at NAFLD. And one thing I do want to point out is that the definition or diagnosis of NAFLD was made using different parameters. And so in 2 of the studies, they used ultrasound evidence of fatty liver infiltration, and the other studies used either MR spectroscopy or transaminase abnormalities. Regardless of the study that was reviewed, there's a higher prevalence of NAFLD in men compared to women. There's also some differences based on ethnicity, and this was very interesting to me, in that Hispanic individuals actually have the highest rates of NAFLD in the country, and African Americans or Blacks have lower rates of NAFLD. And it's felt that these ethnic differences may be due to genetic variation, which I will talk about shortly. There's also differences based on the subtypes of NAFLD that are seen. So in this particular study that looked at individuals who are undergoing liver biopsy, analysis of liver biopsies in individuals who were undergoing bariatric surgery, they found that, again, Hispanics and non-Hispanic whites had higher rates of advanced steatosis, but non-Hispanic Blacks and women actually had more prevalence of NASH. So there's some differences there with the subtypes also based on ethnicity and gender. As I mentioned, it's thought that some of this is due to genetic polymorphisms. The PNPL3 patatin-like phospholipase domain containing 3 gene is the most relevant genetic risk factor for NAFLD. It's a transmembrane hydrolase that is highly expressed on both adipocytes and hepatocytes. And it's thought that it's involved in the metabolism of triglycerides. The Dallas Heart Study was the first study to demonstrate that the RS738409 allele in this gene was strongly associated with hepatic fat content. And this variant is responsible for a substitution of cysteine to guanine. And what they found is that individuals who were G allele homozygous had 2-fold higher hepatic fat content compared to those who were non-carriers. They also found that there were different frequencies of G allele occurrence depending on ethnicity. And this correlates with some of the variances in ethnicity and prevalence of non-alcoholic fatty liver disease, so that Hispanics had the highest frequencies of the G allele variants, where African Americans had the lowest frequency. And of course, as I mentioned, they have lower prevalence of NAFLD as well. There was an Italian study that also looked at differences, or the PNPLA3 polymorphisms, and they found that young patients with NAFLD who had the polymorphism had higher prevalence of subclinical atherosclerosis, specifically carotid plaque and intimal medial thickness. The PNPLA3 is not the only gene variant that has been identified as being associated with NAFLD. I've summarized here a table including other genetic variants that have been shown to be associated with either increasing risk for hepatic steatosis or increasing severity of fibrosis. We know many of the risk factors that are associated with NAFLD. We know that NAFLD is often felt to be the hepatic form of the metabolic syndrome. So it's no surprise that risk factors such as obesity, type 2 diabetes, and dyslipidemia are also seen in patients who have NAFLD. But I was surprised to find that there are other conditions that are also associated with NAFLD. And this is sort of emerging literature, emerging data, that hypothyroidism, OSA, and even some other endocrinologic disorders like hypogonadism are associated with NAFLD. The natural history of NAFLD is that patients who have NAFLD have a higher overall mortality compared to those who do not. As many of you may already know, cardiovascular disease is the most common cause of death in patients who have NAFLD, not liver disease. And the most important histological feature that's associated with long-term mortality is actually the presence of fibrosis. And this becomes very important when we talk about treatment indications. The pathogenesis of NAFLD is not fully understood, but the theory is that it occurs because of two specific hits within the liver. The first being an involvement of an abnormal fatty acid metabolism, resulting in increased levels of triglyceride and triglyceride accumulation in the liver. This is caused by hyperinsulinemia or insulin resistance. And these changes result in the liver being susceptible to a second insult, which is usually precipitated by either oxidative or metabolic stress. This then results with the increased production of inflammatory cytokines, resulting in changes within the liver, causing inflammation, necrosis, and progression to fibrosis and subsequent cirrhosis. So you have to have both of those occurrences to progress to steatohepatitis. The diagnosis of NAFLD is made by serologic testing as well as imaging. Although it is not absolutely necessary to make the diagnosis of NAFLD with elevated aminotransaminases, we do see a particular pattern occurring. First and foremost, the AST to ALT ratio is usually less than 1. AST, LAT levels are also elevated, but you should know that if you see levels above 250, that is less likely due to NAFLD, and you should start thinking about a secondary cause. An alternative diagnosis, rather. The diagnosis includes exclusion of significant alcohol consumption by definition, and excluding other causes of hepatic steatosis. As I mentioned, diagnostic testing using radiographic studies is important, or it can also cinch the diagnosis, either ultrasound, CT, or MRI. Liver biopsy is the best diagnostic tool, but it is invasive, there's a risk for complications, and we can't readily biopsy every single person who we suspect has NAFLD, and neither would every patient consent to that. So it's been really important to have other non-invasive, highly specific tests that can diagnose fibrosis or even hepatosteatosis. There's some clinical decision aids that have been developed to help identify those who are at greater risk for fibrosis, and those include NAFS, the NAFLD fibrosis score, and the FIB-4 index. And these become relevant when we talk about some newer diagnostic tools that are now available or will be available at Emory. But these have been helpful for non-invasive assessment for individuals who have progressive disease. Another non-invasive imaging tool is the transient elastography. And this is an ultrasound test that is able to detect the amount of liver stiffness. Normal liver stiffness is about 4 to 6 kilopascals, and anything above about 12 is considered cirrhosis. And essentially, liver stiffness is a surrogate for fibrosis. And so the more stiff it is, the greater the degree of fibrosis. Dyslipidemia is present in about 50% of patients who are seen in a lipid clinic who have NAFLD. Patients who have NAFLD have a very specific pro-atherogenic lipid profile that is characterized by increased apolipoprotein B, LDL and triglyceride, low HDL cholesterols, and higher concentrations of small, dense LDL particles. Serum lipid profile tends to correlate quite well with the severity of NAFLD as well. So what do we see as far as cardiovascular disease in NAFLD? This study looked at, this meta-analysis rather looked at several studies that compared the risk of coronary artery disease in patients who had NAFLD and those who did not. And you can see that there's a twofold greater risk. of coronary heart disease in NAFLD population compared to those who did not have NAFLD. There are also associated cardiac structural abnormalities that are seen. There's a higher prevalence of left ventricular hypertrophy among diabetic patients who had NAFLD compared to those who did not. There's also a greater prevalence of both mitral angular calcification and aortic valve sclerosis. And this is probably due to systemic inflammation and the atherosclerotic process seen in patients who have NAFLD. This study looked at about 2,000 individuals from the Cardiology study who had concomitant echocardiogram as well as CT looking at lipid fat accumulation in the liver. And they found that patients who had NAFLD had worse strain pattern compared to those who did not. And they also had worse diastolic parameters. So they had lower tissue Doppler velocities and higher LV filling pressures. And this may actually explain the link between NAFLD and heart failure that's observed. Patients with NAFLD also are at increased risk for several arrhythmias, including atrial fibrillation, non-sustained VT, and PVCs. Those with worse NAFLDs or increased severity of NAFLD are also found to be at increased risk for QTc prolongation, even after adjusting for risk factors for cardiovascular disease and other comorbidities. There's also a higher prevalence of, higher occurrence rather, of stroke in patients who had NAFLD compared to those who did not. And this also correlates quite well with the severity of disease. So this study looked at liver stiffness using transient elastography and correlated that with stroke events. And they found that patients who were more likely to have higher liver stiffness parameters, so their liver stiffness was measured greater than 5.6 kilopascals, were more likely to be those in the stroke group compared to controls. So the worse the disease, the greater likelihood that those individuals had strokes as well. Cardiac risk, looking at subclinical atherosclerosis, also correlates with NAFLD subtypes. So this study looked at intimomedial thickness, carotid atherosclerosis, as well as arterial stiffness. And they found that independent of conventional metabolic risk factors or prior history of cardiovascular disease, that patients who had worse fibrosis had worse arterial stiffness, carotid plaque, and increased intimomedial thickness. This shows something similar, again, just looking at the worse fibrosis. So those who had advanced stages of fibrosis also had greater intimomedial thickness. Coronary artery calcification, which we know is a great CV risk prognosticator, was also investigated in patients who had NAFLD. And if you look at the bottom two graphs, you see that of those who had no history of coronary artery calcification, that patients who had NAFLD had greater risk of developing coronary artery calcification over time, and those who had worse disease had a higher likelihood of developing coronary calcification. The top two actually look at those who already had a history of coronary calcification, and you see that there's greater progression of disease with worsening NAFLD compared to those who had milder cases. How much do we know about the prevalence of NAFLD? This was actually a very interesting study. They surveyed primary care physicians and asked them what they thought the prevalence of NAFLD was in the general population, which is graph A, and then in individuals who are obese. And I've already mentioned the prevalence of NAFLD in general population is about 25% and is upwards of 80% in the obese population. Yet 51% of the primary care providers felt that in the general population, the prevalence of NAFLD was less than 10%. So we're way off. And that 54% of them actually thought that the prevalence in the obese population is below 50%. So there's a lot of education that we need to do, even amongst clinicians. And the reason why this is important is because it leads to much lower rates of referral to specialists for surveillance and for enrollment in clinical trials where we can at least start to slow down the progression of disease. This schematic summarizes the multiple mechanisms by which NAFLD exerts this increased risk of cardiovascular disease. And it's a very busy slide, and so I'll simply summarize by saying that we've talked about altered lipid metabolism, the effect of increased circulating pro-inflammatory cytokines, plaque formation, oxidative stress, which we know is important in the progression from steatosis to steatohepatitis, and then systemic insulin resistance, all contribute to the increased risk of cardiovascular events, the arrhythmias I mentioned, cardiomyopathy, and cardiovascular disease as well. So what can we do as far as cardiovascular risk assessment? That involves just what we do every day whenever we see patients. First and foremost, a simple clinical evaluation. While we're not all pulling out tape measurements to assess a patient's waist circumference, we can calculate what their BMI is, order a lipid test to see if they have an abnormal lipid panel, check a hemoglobin A1C and fasting blood glucose for those who don't already have a diagnosis of diabetes. You could consider in those who may be at sort of intermediate or lower risk, rather, using the pooled cohort equation, using non-invasive tools to assess for the presence of subclinical atherosclerosis. For those who have a significant atherosclerotic burden, you may then want to recommend whether it's aspirin or statin therapy to reduce their risk of further cardiovascular disease. Although NAFLD is not one of the risk factors or clinical criteria used for the calculation of the ACC-AHA in the pooled cohort equation, metabolic syndrome is one of the risk enhancers. And so since NAFLD is considered the hepatic form of the metabolic syndrome, one could try to extrapolate that if they wish, but often enough, these individuals may have other risk factors such as high blood pressure, diabetes, and elevated BMI that would be helpful in risk stratifying them. This study looked at the comparison or the association between NAFLD and the 10-year ASCVD risk using the ACC pooled cohort equation and a Framingham risk score. And what they found was that regardless of which 10-year risk assessment calculator was used, that people who had NAFLD had a greater 10-year risk of cardiovascular disease compared to those who did not. So we know that there's increased risk of cardiovascular disease. We know that we certainly need to do a better job of identifying those who are at risk of developing fibrosis and those who have clinical risk factors that are modifiable. So what do we know about currently available treatments? Unfortunately, there are currently no FDA-approved medications specifically for NASH or non-alcoholic fatty liver disease. And so the cornerstone of treatment is lifestyle management. Again, you remember when I showed the slide where you compare steatosis and progressing to NASH, and that 70% of individuals will stay in that steatosis stage. And that really lifestyle modification at that point really has the greatest benefit in preventing progression and treatment of identifiable risk factors and comorbidities. Liver transplant is an option for those who have progressive disease, but that is beyond the scope of today's talk, so I did not touch on that. Lifestyle modification for patients with NAFLD includes weight loss, alcohol restriction, and exercise. There has been some data that there's an inverse relationship between coffee consumption and the risk of progressive fibrosis. So for those who love to drink coffee, who may have NAFLD, maybe this is beneficial to them. But I would caution by saying that this data is mostly from observational studies. So what do we know about dietary intervention? This summarizes a number of diets that were explored to see the effect that it had on weight loss and different parameters of NAFLD. So whether it was improvement of ALT levels, improvement of insulin resistance, NAFLD based on biopsy and steatohepatitis. And regardless of what diet one undertook, so whether it was extremely very low calories of 800 calories a day, or even the novel ones like intermittent fasting, every one of them demonstrated weight loss, improved insulin resistance in the DASH diet, Mediterranean diet, and improved non-alcoholic fatty liver disease across the board using ultrasound. Currently, there's not enough large cohort studies comparing intermittent fasting and its findings when it comes to improved NAFLD based on biopsy. This study I really liked because it really showed specifically how much weight loss was necessary to see some of those changes. And so they found that patients who had at least 5 to 7% of weight loss, 65 of them actually showed improvement of steatosis. But the more weight loss you had, the better. And so that those who had greater than 10% of weight loss, 90% of them actually showed complete resolution of steatohepatitis. 45 of them actually showed regression of fibrosis. So you not only can you slow down the disease, but you can actually reverse some of that simply with dietary intervention resulting in weight loss. And that was simply with just reducing the total amount of calories per day by 750. So you don't have to do these extremely very low, non-sustainable diets of very low caloric intake. What about exercise? We know about the cardiovascular benefits of exercise. Multiple studies have actually looked at the benefit of exercise when it comes to NAFLD as well. And it has shown that independent of weight loss, that there actually are benefits with aerobic exercise in NAFLD. And though most of these studies use different recommendations, overwhelmingly, they all, or a majority of them rather, included the recommendations that we all use from the ACC-AHA, which is 150 minutes of aerobic exercise per week. High intensity interval training, which has been all the rave lately because of the increased post-exercise oxygen consumption and calorie burn after that short period of exercise, has also been explored in NAFLD. And they found that patients who engaged in high intensity interval training actually showed an improvement in hepatic steatosis and cardiac function as well. Resistance exercise is not to be forgotten, and that also has shown a modest decrease in liver fat content in NAFLD patients independent of weight loss. So this is the crux of all the benefits we see with lifestyle modification. So we should consistently be recommending exercise and dietary modification for our patients. For those who are unable to attain adequate weight loss with lifestyle modification, bariatric surgery may be an option. It is not a specifically prescribed treatment for NAFLD or NASH, but for those who meet criteria for bariatric surgery, which means BMI greater than 35 with comorbidities or BMI greater than 40. Can be recommended for patients who meet those criteria and have NASH or advanced fibrosis, but not cirrhosis, because there's a higher perioperative risk for those who have cirrhosis. Some studies show that there has been 80% resolution of NASH post-bariatric surgery, and this is quite impressive. There's a small segment of individuals who had fibrosis pre-bariatric surgery and actually had about 10% of those progressed even after having bariatric surgery. And the thought is that those individuals had at least moderate stage fibrosis going into surgery. We know that surgery results in reduction in cardiovascular deaths and a lower incidence of cardiovascular events in obese adults. And these benefits are primarily a result of improvement of cardiovascular risk factors, such as diabetes, hypertension, and dyslipidemia. So it makes sense why this would then be beneficial to our NAFLD patients who are unable to achieve weight loss on their own. I will say that I have referred a number of patients to our bariatric clinic. And do remember that there's a non-bariatric, a non-surgical bariatric clinic as well. And what I really love that's because they offer, first of all, group counseling. They have a psychologist. They offer nutrition counseling. They have a dietitian as well. One of the limiting factors that I've heard from my patients is really the copay, and that is often not covered by insurance. And so patients have a difficult time remaining in the program over a long period of time. Alcohol use, we know that moderate alcohol use has cardiovascular benefits. However, it has not, we don't know rather whether even light or moderate alcohol use is beneficial in patients who have NAFLD. We do know that heavy alcohol use is detrimental and that it's associated with disease progression in NAFLD patients. And so in the absence of more definitive data at this time, it's recommended that patients who have NAFLD avoid all alcohol consumption. Pharmacological treatments, as I mentioned, in NAFLD patients really centers on lifestyle modification and control of underlying cardiovascular risk factors. In general, any NASH or NAFLD-directed treatments, which is part of the clinical trial, should really be limited to those who have biopsy-proven disease. What do we know that has been investigated in this patient population? Well, there's limited data on aspirin use in NAFLD patients. Much of the literature has focused on cross-sectional studies, but there was one small trial in 2019 that looked at 361 individuals. About half of those, a little more than half of those, were put on aspirin on a daily basis. And they found that daily use of aspirin was associated with decreased progression to fibrosis and less severe histologic features of NAFLD and NASH. And so that's beneficial in some of those who would have benefit from aspirin in general. So not specifically for NAFLD, we wouldn't initiate it just for that. Statins, this is a big area where I struggle with my patients because there's already enough negative information in the media about statin use. And so we're already fighting with that as far as the cardiovascular indications and recommending that for our patients. And now you have fatty liver disease. And so a lot of my patients who have dyslipidemia and have NAFLD, when I try to recommend a statin, they're like, well, it's going to damage my liver even more. And that's not true. So that's where my focus usually is with these patients, is telling them about the safety in this patient population. I've actually seen some primary care providers also be a little hesitant in using statins. And we know that there's no evidence that it will actually induce hepatotoxicity in patients who have NAFLD. And if anything, it may actually improve their liver enzymes. It should, however, be avoided in those individuals who have decompensated cirrhosis. So patients who have NAFLD and high cardiovascular risk or dyslipidemia should be started on on statins as long as their transaminases are not significantly elevated. Renin-angiotensin inhibitors have also been investigated as far as its use in NAFLD because we know that this patient population has a higher prevalence of diabetes and hypertension. And NAFLD patients in this study by Yokohama were given losartan 50 milligrams. These were individuals who had hypertension and had NAFLD, and they found that there was actually a reduction in the liver enzymes. So the liver enzymes and their degree of fibrosis actually improved when they were put on losartan. So this may be the drug of choice for your patients who have NAFLD and hypertension with the other comorbidities such as diabetes or kidney disease, where you would typically use an ACE or an ARB anyway. Insulin sensitizers are important because we know that insulin resistance is part of the pathogenesis of NAFLD. Although metformin is usually the first drug of choice for treating diabetes, it does not improve histological features of liver disease in non-alcoholic fatty liver disease. It will improve insulin resistance, but you're not going to get any benefit as far as histological features. Pioglitazone is a peroxisome proliferator activated receptor agonist. And it actually improves fibrosis, steatosis, inflammation, and hepatocellular ballooning in non-alcoholic fatty liver disease. It improves ALT levels and is actually associated with NASH resolution. The PROACTIVE and IRIS studies have also demonstrated cardiovascular benefits of pioglitazone in diabetic patients who had established cardiovascular disease. The problem with pioglitazone is twofold. Number one, the hepatoprotective events are short-lived. So as soon as you stop the drug, the ALT levels start to increase, which really means that it's possible that the NASH is returning. So all the benefits are lost. In addition, some of the side effect concerns with weight gain, heart failure, bone fractures, and slightly increase of bladder cancer have also limited the use of pioglitazone in general. And so it's not primarily the go-to drug, even though there have been some benefits seen. Because of the role of oxidative stress, vitamin E has been another agent that has been explored in this patient population because of especially its antioxidant properties and anti-apoptotic properties. The PIVENS trial was a pivotal trial that looked at 247 adults with NASH, but who did not have diabetes. And they were randomized either pioglitazone, vitamin E, or placebo for 96 weeks. And a primary outcome was improvement in histologic features of NASH. And what they found was there was a reduction in ALT and AST levels for those who were in the pioglitazone and the vitamin E group. Insulin resistance, as expected, improved with pioglitazone use. But you've got the weight gain that occurs with pioglitazone. And that was about an average of 5 kilogram weight gain in the pioglitazone group compared to less than 1 kilo in both the vitamin E and placebo group. So this is really significant and important. However, there were some good findings in that in the vitamin E group, there was a significant improvement in the composite endpoint, the histologic features of NASH compared to placebo. Not so much for pioglitazone compared to placebo. Specifically, we see that there was improvements in steatosis, lobular inflammation, and hepatocellular ballooning, but there was no improvements in fibrosis with either agent. Currently, the American Association for the Study of Liver Disease recommends you can consider using vitamin E in NASH patients. However, it really has not been adopted widely, and that's because of the increased risk for prostate cancer seen in the SELECT trial and because there are no cardiovascular benefits from the use of vitamin E. Liraglutide is a GLP-1 agonist that has also been studied quite extensively. In the LEAN trial that included, it was a small study, 52 patients, 39% of individuals who were on liraglutide had resolution of NASH compared to just 9% in placebo. And there was no significant difference in the progression of fibrosis. In the NAFLD trial, this enrolled patients who had diabetes who were already on therapy but not well controlled, as evidenced by a hemoglobin A1C greater than 7%. They all received dietary and exercise advice, and they were on liraglutide for 6 months. And as you can see, there was a statistically significant reduction in liver fat content, and that was primarily driven by greater weight loss. So those who had the most amount of weight loss had the most significant reduction in liver fat content with liraglutide. There are a number of drugs that are currently in development. Obeticholic acid was one that seemed very promising. It showed, at least the 18-month interval analysis showed improvement of NASH, but the FDA has requested that they continue with the study primarily because of some of the side effect profiles, and that is that some patients have had mild to moderate pruritus that has been, for some people, intolerable, And there's also been an increase in lipids resulting in necessitating statin initiation and does respond to statin therapy. As you can see, there are a significant number of phase 2 studies, and there are more GLP-1 receptor agonists that are also being studied for treating NASH and non-alcoholic fatty liver disease specifically. What do we know about screening? Currently, universal screening of the general population is not recommended in the United States. One could argue for NAFLD screening in high-risk populations, such as our diabetics or severely obese patients. And I've been told that there is a statement forthcoming from the AASLD providing recommendations for screening of diabetes. Some of the challenges regarding screening is that we have uncertainties regarding treatment options and the cost effectiveness of screening. But one of the good things is that we have some clinical aids and non-invasive imaging that can help identify those who are at low to low risk, or those who are more importantly at high risk for advanced fibrosis. This is a detailed summary of what the NAFLD fibrosis and the FIB index score are. And essentially, if you're for the NAFLD score, if your score is greater than 0.76, it's a 97% specificity for fibrosis, just using the score. And the FIB index score, if you're greater than 3.25, there's high likelihood of fibrosis. So what are we doing here at Emory to address this problem? Recognizing that there are gaps in underdiagnosis, patient education, access to appropriate referral to specialists, and clinical trials for therapies. Emory has partnered with RIMD, which provided a platform that aggregates relevant data and provides analytics and decision support tools to help encourage clinicians to proceed with appropriate diagnostic workup, educate patients, and refer to specialists when appropriate. The platform, as I mentioned, was developed by RIMD. It has been Cerner validated and approved by our Emory IS Tech Review team. The clinical workflow is based on European and American guidelines, as well as protocols used by our fatty liver clinic. And I should say that these subsequent slides were given to me courtesy of Dr. Preeti Rashmwala, who is the clinical director for the fatty liver clinic. Using the NFS and FIB4 score, you're able to risk stratify patients who are at risk for NAFLD and NASH. And so this is what it's going to look like when it launches in a couple of weeks. I think they're expecting that it will go live. It's currently in beta testing, but should be available in Cerner, in PowerChart rather, in about 6 weeks or so. So on the left-hand side, you'll see a tag or a tab that says Remedy. And if you click on that using the patient's clinical history, so whatever their diagnoses are, whether they've had imaging studies and laboratory tests, this platform program will be able to calculate an NFS score and a FIB4 score. And based on that, it will provide some recommendations. Here's an example saying, according to AASLD guidelines, this individual meets the following criteria, and you may want to consider non-invasive imaging for steatosis and fibrosis. And you will be able to order the test yourself, say not now, say you're never going to do it. Maybe you'll defer to referral to a specialist. What I love about it is that there's also a patient-facing part of the platform where you can provide education. And so for the provider, first and foremost, it alerts you that NAFLD, again, has been shown to be reversible with as little as 7 to 10% weight loss, therefore prompting you to focus on lifestyle modification. And then you can choose to enroll your patient in a digital education course. They will get the notification through their patient portal, so they'll get an email link. And this is a sample, a screenshot of what the video looks like. And so this is the module on weight management and healthy lifestyle education, where patients will be able to work through this. And you see they're very short, about a minute or so, understanding what is non-alcoholic fatty liver disease, who's at risk for non-alcoholic fatty liver disease and NASH, and what to do if you have disease. So I like this because it increases awareness, not just for providers, but also for patients. So in summary, NAFLD, as I mentioned, is considered the hepatic manifestation of the metabolic syndrome. There certainly is an increased prevalence of cardiovascular risk factors and some of the criteria for metabolic syndrome in this patient population. Again, cardiovascular disease is the leading cause of death in NAFLD patients, not liver disease. And for that very reason, it's important that we as cardiologists focus on not just identifying those who are at risk, but cardiovascular risk assessments and making sure we modify those risk factors and diseases that are treatable when identified. Tobacco cessation, although I did not touch on that, we know that tobacco cessation is important because tobacco use is linked to progression of fibrosis. Pharmacological treatments are not currently available specifically for NAFLD. However, when they become available, they will be limited to those who have biopsy-proven NASH and fibrosis because that's where most of the benefit is. And certainly, as clinical trials continue to become available, we should be considering all of our patients for enrollment in clinical trials. So with that, I will stop and take questions.
Thank you, Ijeoma, for that outstanding and comprehensive talk. And you stayed right on time, so thank you for that as well. I don't know how you got through 78 slides in right on time. We learned a lot, and while we're waiting for questions, I'll start off with one. A few years ago, this was maybe 5-6 years ago now, somebody had asked me whether there were sex differences in NAFLD. And I felt like it was sort of mixed in the literature, so I didn't comment one way or the other. So can you tell me your thoughts about that? And also, does menopause increase risk of sort of fatty liver disease and then progression to fibrosis as estrogen drops, and what is known about that?
Yeah, so to answer your first question, so there are some differences as far as gender, and I actually had several slides. You're right. In the past, a lot more of the data show that there was a higher prevalence in women, but the newer data actually show that that is not the case, and the larger population-based studies actually dispute that. And consistently, I actually had 3 other slides that I took out that looked at gender differences, and there was a higher prevalence in men compared with women. Some of that is also geographic, and so that in the Southeast Asian population, that there was a higher prevalence in women, and I'm not entirely sure why. But overwhelmingly, the newer data show that there's a higher prevalence of NAFLD in men compared with women. And then your second question was regarding postmenopause and whether or not there was an increased risk of non-alcoholic fatty liver disease. Is that right?
Yes.
Yeah. And so we do see that certainly with increasing age, there's an increase in prevalence of NAFLD, but within women alone, there was actually a greater prevalence of NAFLD in postmenopausal women. And even some studies that compared women who were 50 to 70 compared to men, there was a higher prevalence in women in that specific age group. And as you said, some of that is because of the effect of the changes in hormones and the also changes in the lipid profile with postmenopausal period, where women in the postmenopausal phase of life have, again, a very pro-atherogenic lipid profile there as well. So those are the 2 things seen when it comes to gender and when it comes to postmenopausal status differences with NAFLD.
Yeah, it makes me wonder because for people who have premature estrogen loss or like PCOS or hypoestrogenemia, whether you see more fatty liver or NAFLD, early on.
Yeah, you may, right? Because you also have not just the dyslipidemia, but also the weight gain that comes along with that, right? Mm-hmm. And so you have a little bit more, especially abdominal obesity, pro-inflammatory sort of cells there, insulin resistance that occurs, all of those contributing to the increased likelihood of maybe even developing NAFLD.
Right. Thank you. Any questions from our audience? Type them in the chat, text them to me. unmute and ask. I was struck by the fact that, they didn't specifically list a BMI to target or specific weight number. It's more that even if you get 7 to 10% of your own weight, so wherever you are, 7 to 10% will, help see a nice reduction. That was really good. The app that you showed for Emory, does it automatically link to, I don't feel comfortable necessarily ordering and then following fibroscans for liver, like what to do, like when to follow up again. With this app, are you able to, like, if I see a score that's high, is there a way to just kind of refer to GI fatty liver clinic?
Yeah, so I was asking Dr. Reshmwala about that. I don't think they haven't built into Power Chart where you can automatically, based on this, send the referral. You have to go and do the click the way we typically do. So whether you ask your admin to do that or whether you put in the order yourself, you can do it. But at least, because I agree with you, I may not necessarily feel most comfortable getting a fibroscan. And the other thing is that the transcendental elastography has lower sensitivity in individuals who are morbidly obese. Then you're going to need an MR elastography. And so, yes, from what she's told me, essentially they would welcome all the referrals and rather than ordering the test and knowing what to do with the test results, if you felt uncomfortable with that, you may simply just, based on the fact that this individual has been identified as having a high likelihood of steatosis or fibrosis, that you would just refer them to the fatty liver clinic instead.
Great. Any questions? Your talk was so great and you answered all questions.
It was a very interesting topic. Thank you so much for assigning it to me. I continuously learn so much more about this, and I've got even greater reason now knowing about the improvement in histological features to recommend exercise and weight loss for patients.
That's great. Yes, another reason for sure.
Yay to prevention.
Yes. All right. Thank you so much. Thank you everyone for joining. Don't forget to get your CME credit, and I will see everyone next week.
The preceding program is copyrighted by Emory University.